She's from the US. Okay.
Very horizontal.
Good morning, everyone. Thank you for coming to this room. So I'm Mifatika Lukitasari. Today I'd like to present part of my PhD project. So it's association between visit-to-visit blood pressure variability and cardiovascular outcome. So it's a meta-analysis. So as we know that cardiovascular disease is a leading cause of mortality worldwide, and high systolic blood pressure is the main modifiable risk factor. And recently, the concern about blood pressure has been shifted to from single office blood pressure measurement to visit-to-visit blood pressure variability. There are many studies suggested that visit-to-visit blood pressure variability is a predictor for cardiovascular disease. So uh, we can see at the previous diagram that blood pressure variability is defined as the fluctuation of blood pressure readings over time, and it is categorized as very short-term, mid-term, and long-term blood pressure variability. So, if you're familiar with this diagram at your left side, so it's the result of 24 hours blood pressure measurement. So it's well known as when we measure this, and we'll be able to predict the cardiovascular outcome in the future. But unfortunately, measuring 24-hour blood pressure variability is very inconvenient for the patient, because the machine will measure for each 30 minutes or an hour, especially during the night, and it's quite costly as well. Then at your right side, it's the um, visit-to-visit blood pressure variability. So from this study, they have the measurement from year 0, year 2, year 5, year 7, and year 10. And they estimate the cardiovascular outcome. So now, so of course, we would like to apply this blood pressure variability, visit-to-visit blood pressure variability in clinical practice. Then we would like to use the EHR data, right? Because yeah, that's the only data that we have in real-world clinical practice. But then it will be quite challenging. The first reason is PP data. For EHR data are considered as data that collected with varying fidelity compared to clinical trial data. And HR data, also has variable quality, such as the completeness and high variation in data gathering due to different protocols and also different device of PV measurement across the primary care center. And there is no consensus which PPV metrics should be used for estimating the cardiovascular outcome. In this table, you can see that previous study proposed some metrics. The easiest, the most commonly used is standard deviation, but we have also CV, RV, SV, and VIM. Then the aim of this meta-analysis is to compare the effect size of visit-to-visit blood pressure variability on cardiovascular outcome between studies using EHR and non-EHR data. So this is the method of the study. So we are using PICO approach. So the population for this study is studies that including adult participant age 18 years old, and the intervention is studies that assess visit-to-visit BPV from either electronic heart record data, then observational studies and clinical trial data. And BPV is assessed by based on any metrics, but not limited to the following metrics. Yeah, there are standard deviation, then coefficient of variation, RV, VIM, RSV, RSD, SV of systolic blood pressure and diastolic blood pressure. And the outcome is primary cardiovascular outcomes, such as myocardial infarction, then fatal and non-fatal coronary heart disease, fatal and non-fatal stroke, heart failure, and peripheral artery disease and atrial fibrillation. And we extracted the studies from January 2012 to May 2023, and they are all prospective and retrospective study. These are the keywords for extracting the data. So as a result, we extracted around 6,400 studies from 5 databases, and we excluded irrelevant studies. So we excluded around 3,700 studies, and we got about 3,800 studies for title and abstract screening. And then we did full text screening in 64 studies, and we got 46 studies for systematic review, and we got 44 studies for meta-analysis. So this is the first result. So as we can see in this table, actually the population between HR and non-HR study, it's not really different. So they did the studies in comparable population. And also the number of visits to derive blood pressure variability also, yeah, not really different. Yeah, even though we can see that in non-HR studies, they got a bit more visits. The number of BP measurement per visit similar, and the time between visit, sorry. So for EHR data, the median time is about 3 months, and non-EHR study, the median time it's longer, it's 7.6 months, but the time range is the same, it's 1 to 24 months. And the method of blood pressure measurement for EHR studies, so it's insufficiently specifying the BP measurement device, operator and protocol, while on non-EHR study it's more comprehensive and delineating the BP measurement device, operator and protocol. And the BP observation duration, it's also almost the same. The median time for EHR studies is 2.5 years and 3 years for non-EHR studies. And the outcome follow-up period also, yeah, for EHR study it's a bit longer, it's 6.8 years, and for non-EHR study it's 5.4 years. So standard deviation is the most commonly used BPV metric. So our meta-analysis actually focus on the standard deviation. But here we can see that in this forest plot, the pooled hazard ratio for EHR and non-EHR study, even though the pooled hazard ratio for EHR study is a bit higher, it's 1.21 for each standard deviation increase of blood pressure variability. But actually when we did the subgroup analysis, there is no significant difference among those two categories. And also for CV as the BPV metrics, for ARV and VIM, and sorry. And when we did the subgroup analysis, we found that among studies that used either SD, RV, CV, or VIM, they have a comparable pooled hazard ratio. So it's just like it doesn't matter what kind of BPV metric that is used for calculating the BPV. It will have almost the same pooled hazard ratio. For diastolic blood pressure, so it's less study reporting about this. So yeah, the pooled hazard ratio is 1.09 for EHR and 1.11 for non-EHR studies. So in discussion, so this meta-analysis highlight a non-significant difference between EHR and non-EHR data. So it suggests that EHR data may be a reliable source for prediction of CVD outcomes using visit-to-visit blood pressure variability. And high PPV is associated with CVD in studies in various populations, whether it's in general population, in population with hypertension, diabetes mellitus, or even patient with optimal SPP level. It is interesting, just like if you have the patient that take the medication regularly and they already achieve their optimal blood pressure, but they still have the residual cardiovascular risk. And the visit-to-visit blood pressure variability can capture that risk, and we can manage further about their risk. And investigating PPV in individuals with comorbidities and those with antihypertensive treatment might be useful for designing personalized treatment, whether it's pharmacological or non-pharmacological treatment, and also targeted digital health intervention for addressing residual CVD risk. Then a high PPV from young adulthood is associated with CVD risk and CVD mortality in middle age. But the CVD risk score, maybe the most popular one is Framingham risk score. Then in Australia, we use absolute cardiovascular disease risk score. It's only applicable for those above 35 years old. And yeah, this review finding showed the importance of developing cardiovascular risk score by incorporating visit-to-visit blood pressure variability for primary prevention of CVD. So in the future, part of my study, part of my PhD work, so we would like to analyze the association of blood pressure variability and CVD using linked general practice data set from Western Sydney, and we would like to analyze based on two groups, the young population and the middle age subset. Then categorize the PPV using unsupervised learning, then develop the cardiovascular risk score by incorporating visit-to-visit blood pressure variability in both in young age and middle age, and incorporate this PPV in mobile apps so we can address the primary prevention of CVD. So in conclusion, there is no significant difference in the effect of visit-to-visit blood pressure variability and CVD outcomes between studies conducted with EHR and non-EHR datasets. As such, EHR data is reliable source for assessing PPV, which in turn can predict CVD outcomes. And the second conclusion, actually, this morning I submitted my revised slides, but I think it's not coming here. The second conclusion is the pooled hazard ratio. For every one standard deviation increase of blood pressure variability is 1.21 for studies using EHR data and 1.14 for studies using non-EHR data. It means that for every one standard deviation increase of blood pressure variability, then the person will have 21% increase risk, yeah, 21% risk increase for cardiovascular disease. Okay, yeah, I think that's all of my presentation. Thank you very much for your attention. I'm happy to receive any comments, feedback, and questions. Thank you.
We're opening up for questions. I have one. Is this what you expected from this meta-analysis, for there to be no difference, or were you expecting there to be a difference?
Yes, actually, I expected to be no difference. So we can use EHR data to, yeah, it's quite interesting, right? That I expected no difference. So we can use EHR data to estimate the blood pressure variability. Yeah, because that's all that we have in real world clinical practice, just EHR data.
So you were hoping.
Yeah, and also we know that EHR data is quite messy, so I started to work using that to calculate the blood pressure variability, to extract the data and calculate the blood pressure variability. Yeah, I don't know how to say that. It's a big data and it's so I have to, like categorize based on their visits, such as like it should be 14 days apart uh, between two blood pressure, and how if this patient has uh, more than two measurement each day. So it's quite messy to, to calculate, but I think uh, we'll get there.
Thank you.
Yeah.
CVD is pretty large
Mhm.
condition group, so have you considered? But have you considered categorizing CVD into different like small disease groups? And if you did, like how would you expect that result you just received could be different by different diseases?
Okay, that's a good question. I, so there is, yeah, you're right. CPD is a broad category of disease. So, uh, uh, from those studies, they categorize because they have big data, so they categorize based on each CVD, just like from studies from Guzmanova. It's a large study from US veteran dataset. Um, it suggested that higher visit-to-visit blood pressure variability is associated with higher risk of stroke rather than myocardial infarction. But but again, it depends on my data set that I'm working whether, because it's linked data. I mean, I'm not sure that I will get enough patient for each CVD category. But if I have more patients for each CVD category, of course, I'll be happy to analyze based on each CVD category. Yep, thank you.
All right. Thank you very much.
Thank you very much.
I should stand over here. Our next presenter is Dr. Songmi Kim, who's also my office mate, from Emory University in Atlanta, Georgia. And her presentation is entitled Black-White Differences in Chronic Stress Exposures to Predict Preterm Birth, Interpretable Race Ethnicity Specific Machine Learning Models. That was a mouthful.
Thank you. Thank you everybody for coming. Hope you had a good night's sleep last night after like dancing and drinking. And this is my very first nursing informatics conference, so I'm very excited and very honored to be here to present my study. So before I dive in, I'd like to acknowledge that this study was funded by the National Institute of Health through KO1 Award. So because this is international setting, the racial ethnic disparities in preterm birth, especially in the United States, have persisted over decades, particularly between Black and white women. And Black women usually on average 50% more likely to experience poor birth outcomes than white women. As an underlying mechanism, chronic stress may account for the preterm birth risk
unexplained by the well-established biomedical and behavioral risk factors that is known or reported to explain only 50% of the preterm birth risk. So we believe that machine learning can help more accurate computation of chronic stress exposures. And chronic stressors are multidimensional, interactive, and population specific. And the problem at our hand is complicated, which demands for more sophisticated and flexible methods than linear regression, such as machine learning. As you all know, machine learning is robust at handling high-dimensional data with large numbers of variables linked in interactive linear or nonlinear ways. So far, a wide spectrum of machine learning models have been used to predict preterm birth, from linear regression to deep neural networks, and they have used different data sources and types, although majority use EHR data collected from local hospitals. Only a handful used large population data, although they are enriched in socioeconomic, psychological, and behavior risk factors than just biomedical factors, as well as their findings are more representative of population in the United States. For this study, pregnant women in the United States. Previous studies using machine learning have focused more on improving model performance than understanding the implication of those predictions, which resulted in a lack of interpretability, where machine learning's inner workings are opaque, not intuitive, and challenging to understand. For that reason, my study aimed 4 elements in machine learning models. First, I want accurate and simple model to predict preterm birth more precisely than linear models, but not overfit the data. Also, I want it to be representative to make study findings more applicable to pregnant women in the community. Third, I want it to be race ethnicity specific to illuminate nuanced mechanisms underlying the black-white disparities in preterm birth. And finally, I want it to be interpretable to identify which particular stressors contribute to increasing preterm birth risk to what extent. So this paper aimed to develop machine learning models of chronic stress exposures to predict preterm birth risk among Black, white women, and both racial groups combined, evaluate the model's prediction accuracy, and identify and compare important features for preterm birth prediction among the 3 models. So this study used Center for Disease Control and Prevention's Pregnancy Risk Assessment Monitoring System data, so-called PREMS data, linked with birth certificate data between 2012 to 2017. Our inclusion criteria were first-time mothers who aged younger than 50 years at the time of childbirth, who delivered live singleton birth without birth defect, identify themselves as non-Hispanic Black or non-Hispanic white. Our total sample size, after removing missing data, amounted to about 78,000, representing almost 360,000 women when the CDC sampling weight was applied. So this figure shows a flow diagram for variable selection. So the initial data set contained 669 variables, and after several processes and steps, our final variables had 46 in our model. Our outcome variable was binary, either preterm birth or term birth, because the problem was classification. And our chronic stressors included health insurance coverage, yearly household income, maternal education, receiving WIC, which is a nutritional supplement program for lower-income family in the US, and physical abuse by a husband or partner, 14 items of stressful life events, and psychological distress such as depression before pregnancy as an enhancer of these external stressors. Also, we accounted for several mediators, confounders into account across socio-demographic, medical, and behavioral domains. Of various machine learning algorithms, this paper used multivariate adaptive regression spline, so-called MARS model. As you can see in this figure, MARS computes the nonlinearity by assessing each data point for each predictor as a knot to create a piecewise linear model. So this is a linear but not necessarily linear. Also, it can estimate the relative importance of variables via so-called the generalized cross-validation process. Although MARS model is inherently interpretable, we wanted to enhance model interpretability by extracting feature importance, feature effect, and feature interaction post hoc by using a different method. But this particular presentation only shows feature importance. So here's our general modeling process step by step. So first, we partition the data into training and test sets with the same preterm birth, term birth ratio in each set to make sure that the smaller set contains enough preterm birth cases. And then we build 3 models, the model without interactions, with 2-way interaction, with 3-way interactions. And then we selected the best model via 5-fold cross-validation using the training set, and evaluated the final model on the test set using area under the ROC curve as an evaluation matrix, and then calibrated the final model. And lastly, we computed and compared the feature importance between 2 different racial ethnic groups. So for our subject characteristics, as you can expect, Black women were 42% more likely to experience preterm birth than their non-Hispanic white counterparts. And in general, Black women were more likely to give birth younger and not in a marital relationship, and to have worse sociodemographic, psychological, medical, and behavioral risk profiles than their white peers, with 3 exceptions. So relative to Black women, white women were more likely to have people close to them with drinking drug problems, experience depression before pregnancy, and smoke prior and during pregnancy. So substance use is a huge, relatively speaking, like more prominent in white women during their pregnancy or before pregnancy. So this table shows preterm birth risk prediction accuracy by model characteristics, such as according to the analytic population, whether it was training or test set, according to the degree of interactions, whether the model was weighted, unweighted. But for the sake of this presentation, we're only focusing on the weighted model. So the pooled, combining Black-white population together, and the Black model performed the best with 3-way interaction, while white model performed the best without interaction terms. However, when evaluating in the test set, those prediction accuracy maintained without the sign of overfitting. More importantly, we found Black-white differences in important features in preterm birth prediction. So first, Black model had more important features than white model. And second, the important features differ by race ethnicity. Third, only Black model identified chronic stressors and they correlate as important features. So this figure shows the feature importance for non-Hispanic Black women, and the top 4 important features in preterm birth prediction for this population included PROM, pre-rupture of membrane, the number of prenatal care visits, medical risk factors, and the US state. And those important features were followed by several other features. However, I like to highlight that this model identifies several important chronic stressors, including maternal education, income representing women's socioeconomic position, drinking drug problems of people close to the mother, moving to a new address, imprisonment of husband, partner or self, and physical abuse during pregnancy. Likewise, Black women identify top 3 important features similarly to Black women, such as number of prenatal care visits, prom, and medical risk factor, although the order is slightly different. Those 3 important features were followed by BMI before pregnancy and the start of prenatal care in the first trimester. So in summary, Mars models classify preterm birth with fairly high accuracy with AUC over 0.7 across the analytic population, although I acknowledge a lot of room for improvement. There were commonalities and differences in the important features to predict preterm birth between Black and white women, specifically the number of prenatal care visits, prom, and medical conditions before and during pregnancy were the most influential for both racial ethnic groups. However, only the non-Hispanic Black model identifies several chronic stressors and thereby medical and behavioral correlates as important features. Although I didn't dig deeper, we also observed a state-level variation in preterm birth risk at the population level, only for non-Hispanic Black women. All of these point to the critical role of social determinants of health and the racial ethnic differences in preterm birth, especially in the US context. This study has limitations. Because we use secondary data, this did not allow us to predict subtypes of preterm birth, such as medically induced, spontaneous, iatrogenic, which may have obscured more nuanced predictors for each subtype, reducing the clinical relevance. Also, this study included individual level factors only, although the data set contained factors beyond individual levels, such as social support, perceived racial discrimination, and perceived neighborhood safety, but those variables were collected only by a handful of US states, not even at the same time. So I had to choose a larger sample size over the inclusion of more social determinants of health. Also, this study did not consider biological responses to chronic stress exposures, which could have improved the model prediction accuracy. So in conclusion, interpretable and race ethnicity specific machine learning models using nationally representative data can capture the way chronic stressors work, and by doing so, they can eliminate the chronic stress mechanism of preterm birth unique to Black and white women, informing tailored prevention strategies. Thank you very much. Questions?
Did the OBGYNs at Emory put in cerclage in these women?
That's a great question, and that could be one of the predictors of preterm birth through the literature, but the CDC did not collect those conditions for women, unfortunately. So there are a lot of limitations inherent in secondary data, but if that predictor was included in data, that could be listed as one of the important predictor for preterm birth, but I could not include that variable. But probably if I used EHR data, that predictor could have included. Is that what you?
Yeah, and then a secondary question is, did you do any anthropomorphic measurement of the cervix to the uterus and the vagina?
Thank you for that question, but unfortunately, that data was not part of the CDC's data because CDC focuses on public health, population level predictors, more like behavioral, psychological, socioeconomic variables rather than clinical indicators. So if that data also were involved in the CDC data collection, that could have changed the preterm birth prediction, but unfortunately, the CDC data did not contain it, but it has also its own value, like predicting population level preterm birth prediction, which is predominant in the United States.
I'm going to predict that the differences between the black and the white population relates to those two clinical variables
I see.
and physiologic variables
Okay, yes.
that they may make a huge difference.
I agree with you. So as I acknowledge, these data also have population impact, but may have like reduced clinical relevance. So maybe we have like different approach clinically, like different strategies, but population level, we have also target social determinant of health to tackle this problem. So I really acknowledge your concerns and appreciate that. Thank you.
Actually, my question is not really focused on your purpose of research, but the second slide, can you show me that, the graph? Yeah, I'm a little bit interested as Asian. The Asian is lower than white. So do you know any reason why that? If you look the data or something?
That's a great question. First of all, I'd like to acknowledge that Asian population is not considered as a sort of disadvantaged minority population in terms of NIH definition. So we believe that Asian, one of my research considers sort of marital status as like this a proxy for social support, and majority of Asian populations give birth in a marital relationship, and that may have served as a social support factor. And also this is like population level aggregating the maternal age, but I'm highly interested in disaggregating this population according to their maternal age, because I believe that maternal age can serve as a proxy for women's stress exposure or experience of stressors throughout their life course. So when we disaggregate the data according to maternal age, the pattern may change. But this is like aggregating data, and on average, like every so many health outcomes or diseases, Asian population are better off than other populations, which partly contribute to that a lack of interest in studying Asian women's health and their behaviors, because they think that Asians are better off than other racial ethnic groups. They're not disadvantaged. But I like to also acknowledge that they have their unique risk and protective factors for their health and disease conditions, but that should be more studied. But currently, there's a huge gap between black and white model, like black women's maternal morbidity and mortality is one of the critical issues in the United States for many reasons, historical reason and so many other reasons. So many of the fundings and research really focused on black-white differences, but I hope that over time, researchers study like other disadvantaged, racial ethnic minorities or minoritized populations to study different health conditions, including poor birth outcomes.
All right.
Thank you so much.
Okay, I will introduce the third hour presenter. I'm happy to here as a moderator. It is my first moderator in Nursing Informatics Conference. So, yeah, thank you. And our third presenter is Hu An Lee, National Health Research Institute of Taiwan. So he will present the precision nutrition management in continuous care, leveraging AI for user-reported dietary data analysis. Okay.
Oh, it's mine. Sorry. The first page, provide this one, so I put it inside my first page. Okay, hello everybody. So today I want to introduce precision nutrition management in the continuity care, leveraging AI for the user report dietary data analysis. And actually, this project is collaborated with our Ministry of Health, and is doing kind of the nutrition survey in our population. So we support them to design this kind of application and the AI model to improving the efficiency of a Taiwan National Nutrition Survey. Okay, so this is the outline. So first of all, the introduction, and we can know the proper nutrition for disease prevention, management, and treatment. So relationship between nutrition and health is well established, but still not too many. I think in the nutrition side, it's hard to really recognize and identify. It's really correlated with the health right now, because it's hard to doing like kind of the blood testing or the follow-up and anything. But a lot of significance shows if you change the dietary way and the nutrition intake, you can get more health, life, and then for your body. And also the nutrition and health support to the immune function. So nutrition-rich food can support the immune function and can make the body more resilient to infection and reduce the risk of illness. And also can contribute to the overall health and the prevention of onset or many chronic disease. And also for the many different chronic diseases, include such as diabetics, hypertension, and cardiovascular disease, require the carefully management of the nutrition intake. That is for the clinical guideline that I already told you about that. So for the nutrition and disease management, for including the diabetic management, blood pressure management, and the inflammatory condition, and the enhanced medication efficacy. So that's a different way for you to intake the nutrition and then to correlate it with your health right now in the clinical guideline. But actually, it's hard to really recognize about how it impacts with your healthy. So the importance of the adequate nutrition, the key role in the tissue repair in the immune function, and also it's improve the quality of life, and the precision nutrition intake control is fundamentally components of the disease control right now, and it's help prevent the onset of disease and plays a pivotal role in the management existing health conditions, supporting treatment and improving the overall well-being. And another side is personalized guidance. So in our research, we focus on the design this kind of the nutrition suggestion system based on the AI, and we want to base on the personalized disease control, and then disease background, and then their body vital sign and everything to design the personalized guidance for them. So let's show up some timeline of the nutrition national nutrition survey in Taiwan. So the national nutrition survey started from the 1980s, and then they in the initial survey using the actual food measurement, and then the 1990 to 2000 nutrition survey for the elderly. And then the next about 10 years, there is a trend to the series of nutrition and health survey in Taiwan for the different age groups. And then the next step is 2013 to 2020, the survey model shift to a 4 years cycle, completing the 2 cycles right now. And every year, start from the 2013 to 2020, every year they have 2,000, average is about 700 people. So which means right now actually in the Taiwan population is more than 23 million. So which means it's really slowly and take a heavy burden to the dietitian to do in this way, because every time they need to do in the in-person survey for more than 2 hours for the one case. And it's they're really doing the very detailed surveys, including what you take, what you intake in the past 24 hours, and then they were asking about is too salty or not salty, too sweet or not sweet, and then they will a judgment by their way, and then they will also asking the portion size about what you're taking about. So that is a kind of the asking and then respond by the citizen themselves. So sometimes everything is based on their memory, and it's hard to recognize that is real, that is true, or that is a really situation right now. So everything just is kind of the related the way to doing this. So from the 2021, the survey renamed to the National Nutrition and Health Survey and continually the 4-year cycle. So actually our project starts from the 2021 actually. So we working with our Ministry of Health, and then we try Ministry of Health and Health Promotion Administration. So we try to design this kind of the AI model and the AI system to allow our nutrition survey team can use, and then next step is to push back to the user self, and then we can make the user doing the survey by themselves with more efficiency. So for the literature review, the traditional method of assessing the dietary intake is including the paper-based or interview-based dietary record, and the measure is using a 24 hours dietary record and the food frequency questionnaire. And also they consider the golden standard approaches, so everything is follow the WHO's initiate some golden standard. And the potential issue is right now as I mentioned before, is a recall bias and the limitation in the food composition database, and the challenge related to the research personnel and the time cost. So that's why I'm talking about that is very working hardly, and even they hire more than 20 dietitians every year, but they also only can doing about 2,700 people each per year. So another side is we try to figure out which kind of application we need to design. So we analyze the functional feature of the diet and the nutrition mobile application. So we just searched several different papers in the Google Play Store and the App Store, which including the Android and the iOS assistant. So totally we find the 13 applications, including the analysis. 9 of them had a food dietary recording function. And then this all the text input, everybody is based on the text input, and our barcode scanning is 78% to select food item, which means they need to put the data into the database, and then they can scan the barcode directly. And then additional feature, 33% had a feature of the adding receipts. That means you can put anything you want to put in by yourself. And then that only 7% for the collecting the water intake. So of that dietary application primarily focus on the energy balance between the dietary intake and the physical activities. So we also based on this way to doing the personal health suggestion. And then the key feature of the mobile application for the dietary recording, I think the ubiquity and the portability, that is a more important way. That means you can use in the system and then doing the record by yourself in any place. And second one is real-time recording, because maybe you will forget what you intake and what you had today, and then it's online capability. So which means right now everything based on the cloud, based on the system, you should online, and then connectivity, which means not only connect to the internet device, but maybe we can connect to our family's information and others' personal health records information. And then enhance the convenience, we need to update the food list every year or every month or every week, depends on what you have. And then the automatic suggestions to provide to the patient self, they can do, provide to the user self what they can intake. And the intelligent prediction in the health recommendation system, it should be intelligent enough to predict the patient or user's physical health condition and the social activity and the record. And then next step is deep learning the method to comprehensive the active engine to execute the health recommendation system within the big data analysis application. So for our methodology, we separate to the 5 steps. And in the first step, we design the requirement getting to and the analysis. And the second step is we design the AI model and model construction, and then the nutritional calculation and the feedback mechanism is what we're doing there. Okay. And then we testing and optimize, and then we ongoing right now maintenance and then improvements. So in the step 1, we collect the food receipt. We totally more than 1,800 food receipts inside there, and the food ingredient is more than 8,000. And then we're doing the calculation of the nutritional. And then based on the dietary guidance of the Taiwan, we suggest daily nutrition intake. And then a daily nutrition balanced dietary is recommended. And in the second side, we using a lot of different natural language processing analysis via the LIST-our system. So in our system right now, we can accept the text, the image, the voice, and then everything will change to the text and then go into our analysis system. So that is our according to the dietary guideline Taiwan, and based on the gender, age, and activity level to make sure which kind of how many calories you should taking every day. And then we separate to the 6 different categories of the food and suggest you to intake. So this is a very draft one and only separate to the 6 different categories of the food intake. And we testing scenarios according to the dietary guidance of Taiwan and required nutrition intake and the recommended portion size for 6 categories of food. And then also we're doing based on the individual's nutrition intake status, the system selects suitable dietary option for the recommendation. And also we monitor system and operation to address the potential issue and the error. And also we connecting to the nutrition system to a live bot can offer to several benefits as following. So for the results, yes. So for example, it's a female 39 years old, 162 cm, 66 kilogram is essentially low activity function. So we will suggest that you intake about this one, and then middle one is we calculate about the previous week what they're taking, and then we based on the list 2 information we will recommend another food dietary receipt list, and then we just calculate for her, and maybe this one is what you need right now, and try to get in the balance. And then also we contact to the live bot, so which means we can put the award here, and then we will doing analysis to several different 6 categories of the information, and then you can put what you intake the food. So the AI model will analyze what you intake right now directly, and then also show you the feedback about how you intake, and then separate to the 6 different categories. And this is final the result. We adjustment. We also asking the nutrition evaluate and the system evaluate compared to the difference. So finally, we find for the for the analysis by ourselves and then analysis by a dietitian. Okay. The five kinds of the category will not significant different. Only the one is whole grain, a little bit significant difference. So we still figure out how to fix it and then adjust our system. So the conclusion is about addressing the challenges of traditional dietary assessment method, and then we user empowerment, and the live bot enhance our user experience with a personalized feature, especially for the elderly. And also we try to doing some kind of AI-driven solution for continuity care. Okay, thank you very much. Okay, so this is what I job. We still need to, announcement. We will hosting the MedInfo 2025 in the next year. Everybody should, if that is possible, please submit your paper and welcome to Taiwan. Okay, thank you everybody. Yes, sure, definitely.
Great work. It's great to hear that you can take multiple data modality, including the user text input and also images, right? My question is, do you see a difference, for this nutrition estimation for users who input using, just text input versus those take a picture?
Actually, for the picture size, not really accuracy right now because the Chinese food, like a Korean, like Japan, they always fry everything together. Like a fried rice, like not compared to the American or European, that's kind of the original food, like a steak, like a baked chicken, a baked pie. But everything in Taiwan always is mix everything together and then fried. So, for example, sometimes it's hard to recognize which kind of vegetable inside there. So that's why we separate to the 6 different categories of the food, because if we only calculate into the nutrition content, actually we had calculated how many nutrition content you're taking for about the 68 different items. But from that side, it's more significant. So from right now, we just separate to the 6 different categories. That is easy because vegetable should be vegetable. Not if it is a cucumber or is another green vegetable, that is separate. That will include into the vegetable part, the category. So for right now, we still need to figure out how to really recognize the food content inside our picture. That is the first part, and then second part is hard to recognize how many portion size right now, because we cannot doing the kind of a 3D analysis within the one flat image right now. But for the text size, we can asking them how many you taking and which receipt you take, you take, and then you can adjust by yourself. So the way we're doing is you upload your image, and then we analyze which kind of receipt for you, and then you should adjust it by yourself. So you can put, if this beef noodle, and we put the tomato inside there, but the receipt didn't have the tomato, you can add on by yourself. And if we say inside we put an onion, but that is from the receipt side, but you're really not taking the onion, so you just remove the onion by yourself. And that need to adjust it by yourself, actually.
Got you. And for the image recognition part, do you guys train your own model or you are using some pre-trained model to do that?
Actually, we training by ourselves because the Taiwanese food is hard to getting some already trained. We search on the Singapore. In Singapore, they have one, and then Malaysia they have one. Actually, that is accuracy is very high. But actually, it's also expensive. So for government project, they always don't want to keep paying something for the other supporting. So we need to decide and doing the AI model by ourselves. So we just taking a lot of photo and searching a lot of photo within the same food. So actually, in the past 3 years, I taking more than 200 bowl of beef noodle because we just need to take in a photo and design the AI model by ourselves.
Oh, that's wonderful. Do you guys have plan to release this wonderful public data set to the public? Because in machine learning, labeled data is really scarce and valuable to the community. I wonder what's your thought on that?
Yes, I think once we get in the more stable performance about this kind of the natural language processing model, and then also the AI model. We will try to release everything into the open source platform to show to other people, and then maybe because in that way we want to other people using our data sets and using our algorithm to tell me which part we can improve and we can getting better. So I think that is kind of the public collaboration together.
Sounds great. Thank you.
Thank you very much.
Thank you, Xian Li. You are very did a good job. I'm really look forward to the next step or the upgraded version in MedInfo about your research. Okay, the next presentation is Rojada. She is a very active researcher in nursing informatics and nursing informatics SAP group 2. So please, yeah.
Thank you.
Yeah.
Thank you very much for having me here today. It's been a quiet journey to come here all the way. They lost my luggage, first of all. So it's been a little crazy. Yeah, I'm going to show you. This pretty much is like a little narrative of something that we do and we're doing in Mexico with nursing informatics. As we know, health informatics has helped the whole world. But for rural areas like in Mexico and for community nursing, there's still a huge gap for using informatics. So we have been doing tons of efforts to make this shorter, to short this gap a lot, but still, we're still having a big challenge coming. During COVID, telehealth helped a lot in Mexico, and people like from 8.9 million people using cell phones, it raised to 98.6 people using it. We are 126 million people in Mexico, so we know that technology is getting there. However, in Mexico, just in Mexico, we have 68 indigenous groups and 11 linguistic languages around. Just in Oaxaca, Mexico, that is south of Mexico, we have 275 indigenous groups that from them, 10 of 7 people in Oaxaca, they are indigenous. So we have a very good, a large group of indigenous people over here. From that, we know that some people have a lot of internet access and stuff, but that's very different, for example, for that small community. So some of the stuff that we're facing, or the challenges, the big challenges that we're facing in Mexico are related to internet access, just the social way that people are and the culture that we have, the psychological factors too, and of course, governance and government too. Because of this, not everybody is reaching or having the same opportunities to have access to internet or nursing informatics. As we know, nursing informatics has been, we talk about it, there's even this conference about it, but in Mexico, nobody knows much about this. It's a concept that not many people understand and not many nurses understand. So that's why in this University of Puebla that I work, we are like pioneers of talking about this and bringing this concept down to Mexico. 6% of the hospitals, the private hospitals in Mexico, are using technology and are using health informatics and very little nursing informatics. 3% of them have implemented now the ER records, but still is very, very little in comparison with other countries. I want to tell you a story here about this community that we visit. We have 2 clinics that are part of my university. One is established in a small community south of Mexico, in Puebla. And in this community, we have a clinic that actually reached 12,000 people, that from these 12,000 people, 9,000 live in extreme poverty, like they're super poor. And having that community, we're still not having enough nursing informatics programs to teach students how to reach to them. We don't have enough support for technologies, and of course, funding is always a problem. So even if we know that you guys talk about a lot of technology and robots and machine learning and everything, for us it's still very low in that aspect, no? So Besides that, I want to show you this story before we get all the way there. But things that nurses and community nurses do, they try to close this gap. They try to contribute about primary health. I want to go a little faster, so I want to show you these pictures before I go to these formal conclusions. We're going to show you how we work there. To reach to these people, we have, I have normally 15 students, and we form like teams of 5 to walk the community, first of all, to see how the community works around the social determinants of health. And these walks take 3 hours. 3 hours to take to a house that is all the way on top of a hill, and it's very hard to reach these people. There are people that they don't want to come to the clinics or the hospitals because they don't trust nurses, they don't trust doctors. They're like, no, I don't want to go. But when you do home visiting and you bring the students and they see the nurses, they get very happy. It's like, oh, you're here with me. And most of them are like elderly people, they're old people that they're in the communities living by themselves, mostly because of the son or the daughter moved to the United States looking for better job opportunities. Here, as you see, we have a patient. His name is Jose. Jose has been alone living in his house for almost 11 years. His wife passed away, and he has this son with a lot of problems of mobility and stuff. Here, he got sick, and he said, if you don't come, I'm going to die in my house. So we said, no, we have to help him out, right? So we brought the students over after a long walk, and we checking him. He has diabetes. He has tons of health problems. And what we did, we were helping him out. His son has a lot of mobility problems, so we put out there, like, we were looking for pillows. You know, pillows is something very common for you guys. You have pillows in your house, you have tons of pillows over there, but pillows for this family was a huge difference. We got 4 people gave us 4 pillows that make a huge difference to help him moving his body around his bed because he was there lying there 24 hours. We showed the father how to move him and using the bed. And we sent him text messages and we sent him WhatsApps as friendly reminders. That is a baby nursing informatics intervention. And we post these posters here, has a clock, you know, showing him how to move him. And these are my students very happy that they help him. We also have animals too. Everyone that needs nurses, we are there on the way, and we were helping these poor dogs that they have no food or anything. So, and this is my patient. Her name is Seferina. When I was a bachelor student, I met her in the community. She was diagnosed with diabetes type 2. So around her journey with diabetes, everything has been so difficult for her. Right now, she has kidney problems, and I brought the students, and they were so happy to see me back after so long. And she keeps her treatment, but however, she's still very sick. That day, we brought her food. Food in Mexico is a big tradition, right? If people give you food in Mexico, you're more than welcome to a house. Even if what they only have is tortillas, you know, like something very, or beans, you know, they give you that. So we were teaching her some stuff related to that. We took this beautiful picture, and she wanted to have the picture forever. So one of my students, what she did, she printed out the picture, and the next day, she had it in this little frame for her. So what we're doing pretty much is we're bringing not a huge technology, probably not robots, probably nothing very big, but little text, little information that they can reach. Some of my bachelor students are working on that little educational materials and how to validate the materials. And my master students, they have validated information for applications and everything. And that's pretty much what we do with these students. What we put there is we put our hearts in what we do. We put passion on what we do. And even if we don't have that much technology, I think the beginning for nursing informatics is to put your heart over there. So it's something that people might not understand because you have access to all of these, but it's just beautiful. Thank you very much. Yes.
Thank you so much for what you're doing, and you're narrowing the gaps in practice and not to mention the research. I really appreciate that. But I'm more interested in like the program itself. Like you to reach out to these populations, you had to walk 3 hours, right? And then how do you follow up with your patients? Like how regularly
Yeah.
do you meet them?
What we do, we train these nurses, and we have 6 months courses, and then another group comes, and another group comes, and another group comes. So what we do is we connect them by paper files, because we don't have anything electronic records, but we connect them by the files that we leave, so they can give the follow for the home visiting, and they do home visiting for them, and they keep following. The university gave us a bus that takes us to the community. But inside the community, you have to do the walking yourself. So that was pretty much what we do. We do follow-ups by home visiting for the next group and the next group and the next group.
Another question. What are your population of interest, like most urgent health issues? Like what's the needs?
Right. Well, they're huge needs, right? But most of them are patients with diabetes. So we need a lot of insulin, and we need medication too, clothes, and yeah, for food, it's good because the husband, he has his own little ranch, he grows stuff like corn and beans, and they save the beans for the year, and they actually portion the beans so you can eat it through the year. Of course, there are some little stores where you can buy stuff, but they don't have enough money to do so. So the wife used to do the handmade tortillas, in the past, but now that she's sick, she can't do it, so they get the tortillas from a neighbor, and they are eating it with beans over there. It's like a soup that they prepare, but it's all carbs, so what we try them is to teach them not only in the tortillas and the beans every day, because, you have diabetes and you have all of these problems, but it is a big challenge. It's just, let me tell you, that is the reality, Yeah. I think it's off, yeah. Yeah, it works.
Yeah, it was off, sorry. Hello, my name is Antonia from Chile. Well, first of all, thank you for your presentation. It really touched me because also in my country, we have some of this reality, people who are left behind in the middle of nowhere, and they have so many needs that even speaking about technology feels so off. And thank you for what you're doing. I think it really represents the essence of care that we never have to forget as nurses. But I want to ask you a question. Since you're already connected with this community and you know what they need and what their problems are, how do you envision that a technology problem could actually help them? Just for one moment, forget that I know you don't have many resources and you're just doing what you can with your students. But how do you dream with a program that involves technology, and how do you think this could be a game changer for these communities that are left behind?
Yeah. This community, they do have internet access. There is access in the community. So there are stuff that makes the internet to come to the community. However, they don't have it. But for example, imagine you saying that I don't have a problem with money, right? I think having a little monitor, a screen that we can do telenursing, to give following instead of walking 3 hours to see them. They could see me on a screen and talk, hey, and it's me. And I'm probably teaching because I have to do 30 hours of teaching every week plus everything else, So it's it would be so nice for them to have probably the students there, but my face over there. So because they trust me. And a labor of this home visiting and working with these kind of people is a long process of trust, it takes time for them to trust you as a person, to trust you as a nurse. So if they see me in a screen, it would be so nice for them to see, oh, it's her, she's there, even if the students are taking my blood pressure or checking my glucose, she's there. That'd be so nice to have this tele-nursing, right there for them. It would be very nice.
Super, thank you.
You're welcome. We have time a little bit. I went fast because I got emotional, you know. It's something that I really love doing. So it's like something that really touched my heart. And I know it's hard to come here, and I did all these efforts to come and to see your faces again. And I've been here coming for almost 8 years for this nursing informatics. And what I put here is my heart every time I come, because I get out of like great people, get to see my friends, and it's just very nice. If there are not any questions. Yes.
Thank you for sharing your meaningful and very thought the story about you. I think they are kind of lucky because you are going to there. So do you have any criteria or the reason why you choose them?
Yeah. When we every time that students get there, because we have this clinic, we have already done like this many, like we go and find them like houses and people that have needs. And we have like an evaluation, like a survey that we have, and we apply them to every family. We have 2,400 families of that community. So in that survey, we start, like divide them who needs us the most, and we go from them to the last one. So that's pretty much how we do it. Like technology, as she was saying, if money weren't an issue, we could do something too, like to make that faster, right? Because we're doing it by hand and we're using paper, but if we could just make it faster, it would be using technology for sure. So I have heard many people saying that they know exactly what they want with technology, but when technology doesn't match what you're actually doing, is when the reality hits you in the face and you say, wow, it's like their reality. So yeah, that's the way we chose them. Like, we go by the necessities that they have. We have a waiting list of people that haven't been able to reach them, because the students, as I said, they keep coming every 6 months to the community, and we keep coming every day to see them and giving follow-ups.
Yeah, okay. If you don't have any comment or question, may I close this session? Yeah. Okay. Okay. Thank you for joining this session, and see you in the next session. Yeah. Thank you.
Thank you.